It's our pleasure to welcome you everyone in our fourth pathology workshop at Bahia Conference. Some interesting pathology cases cases from pathology and radiology department will be presented, as well as topics from pathology. The first talk will be presented by Dr. Mohammed Zaqqouq, consultant of pathology at Bahia Hospital and lecturer of pathology at National Cancer Institute. His talk is entitled Tumor-Stromal Ratio in Breast Cancer Using Image Analysis. The floor is yours, Dr. Mohammed.
Thank you.
Thank you.
First to present myself, Mohammed Zaqqouq, lecturer of cancer pathology, National Cancer Institute, and consultant pathologist at Bahia Breast Cancer Center. My talk today about the tumor-stroma ratio in invasive breast cancer and using image analysis. There is a strong need to improve the prognostication of breast cancer patients in order to prevent over and under treatment, especially when considering adjuvant chemotherapy. Assessment of stromal component in solid tumors and its crosstalk with the tumoral component has become increasingly the center of extensive research. Tumor stroma characteristics might be valuable in predicting disease progression. And going back to our talk today at the TSR, at the tumor-stroma ratio, it's a way of expressing the amount of stroma in the tumor, which can be either determined by the percentage amount of the tumor or the stroma. So for example, if I have a section and a field and I say, for example, that 70% of it is a tumor and 30% is a stroma. Most of the literature will refer to the TSR as percentage of tumoral stroma. So when I say high TSR, it means a stroma-rich tumor, and low TSR means stroma-poor tumors. However, there are few studies which treat the TSR as a mathematical equation. So it is calculated by dividing tumor area over the stromal area. So here, humor TSR equals stroma-poor tumor. For simplification, till the end of the lecture or the presentation, I will add this slash. The slash here to delineate the difference between the regular and if I use it as a mathematical equation. This was first described in colon cancer back in 2007 by Mesker et al. And in most of the papers after that, you will find this one is mentioned. And even the cutoff value, the 50%, you will find it according to this previous one. They determined the cutoff value according to their significant correlation with overall survival and disease-free survival. So they have used the 40%, the 50, the 60, the 70, the 80. Okay, the 50% has a significant p-value and significant correlations with overall survival and disease-free survival. It's not only the 50, also the 60% and also the 70%. Okay, so which one to choose? The 50. Why? Because it has the highest p-values, the 0.001 and 0.00. So the 50% was used to divide the cases into high stroma and low stroma. The first one to describe it in the breast cancer was De Cruyff in 2011, and actually the paper has been submitted in 2009, so it's just 2 years after the Mesker et al. And larger proportion of the articles published in the literature will be regarding the triple negative. However, there is increasing amount of papers for the whole cohort and for the luminal phenotype. Okay, what about the TSR in the other tumors, which has been studied since 2011 till now? Especially the GI cancers are the one of the common that the TSR is evaluated in it. In the first study by Orello et al. Gastric cancer, the 50% was used, by eyeballing. It doesn't, they use the just by eye examination on the routine H&E sections, and they found that stroma-rich tumors correlated with larger number of positive lymph nodes, advanced TNM stage, lymphovascular invasion, perineural invasion, and significantly shorter overall survival and disease-free survival. Similarly, in colorectal cancer, stroma-rich has been correlated with lower disease-free survival. And here the 47%, this is a specific number because it has been evaluated by image analysis, and this value has been determined using the statistical area under the ROC curve. The third one is a review of TSR in the digestive tract cancers, and it implies or it concludes the same results. The stroma-rich tumors have lower overall and disease-free survival. Similarly, in non-small cell lung cancer, the same. Epithelial ovarian cancer, stroma-rich tumors have advanced stage, more lymph node metastasis and recurrence, shorter progression-free survival and overall survival, nasopharyngeal carcinoma, and also solid tumors. So what to get from this, that high stromal component is related to relatively poor prognosis, and the most pronounced prognostic effect of this parameter in breast cancer seems to be observed in the triple negative phenotype. TSR assessment might represent a simple, fast, and reproducible prognostic factor at no extra costs. Despite these advantages, a robust clinical validation of this parameter has yet to be established in prospective studies. This is an example. The image to the left represents a stroma constituting about 90%, and to the right, vice versa, the tumor consists, the stroma is only 10%. The next one, images on the left are for the same case. The tumor represents 80% and the stroma only 20%. The one to the right, the tumor constitutes only 35%. Okay, what about calculating, and when I started the lecture about how this can be represented in two ways. Okay, if I say the percentage of stroma present, I can say that the tumor stroma is about 65%. Therefore, the tumoral component is 35%. So if I am dealing with a paper that deals with the TSR as an equation, it will be 35 divided by 65, so the TSR here is called 0.53. Okay. In our work, we have used 107 breast cancer core biopsies. They were selected and stained using multiplex immunofluorescence for TME immune cells. The main purpose of the study was to examine the tumor microenvironment immune cells. The whole slides were scanned digitally, and the TSR has been evaluated in all cases using an open software called the QPath, while a subset of cases, 88, were additionally analyzed using the Inform software. The QPath is a powerful, open source, flexible software platform for bioimage analysis. It was developed at the University of Edinburgh. The second softwares are consisting of two, the PhenoChart and the Inform. The PhenoChart is used for slide viewing and annotation. For example, this one, it's called ROI, regions of interest, and then these regions of interest are then subsequently analyzed using the Inform software. This is an example. This is an image of core biopsy of 3 cores of breast cancer. And this is after it has been stained using multiplex immunofluorescence. And the reddish areas are the staining by cytokeratin. And yeah, these colors are because they are not stained using immunohistochemistry. It's an immunofluorescence. So the colors even these colors I can play with. I can give each length wave a different color. So here the red ones are the cytokeratin staining. And then this is followed by the manual annotation that I made by myself. So for example, I used the red to delineate the tumoral area and the blue to delineate for example, the whole area of including tumor and stroma. And then through the software, I subtracted that tumoral area from the total to get the stromal area. The other way is by the Inform software. So this is another example, a core biopsy showing 2 cores of breast cancer. And this is after it has been stained. And these blue rectangles are the annotations that I made, that I choose. I didn't make, I choose to be further analyzed using the more complicated software. Okay, we will take this one. Okay, it is the same. It is the one when it has been transformed to the Inform software. And this software is machine learning based. It means that I give him a bit of teaching. For example, I can go around this one, make an annotation and tell him that is a tumor and an area here, and this is a stroma. So after some times of training, it will get this. The red areas, he already chose it as a tumor, and the green is the stroma. Okay, our cohort comprised of luminal, HER2 positive, and triple negative, nearly 1/3 for each of the 3 types. Grade 3 cancers, about 50%, and grade 2, 36 cases were inflammatory breast cancer. The median TSR by the slash, as assessed by the QPath, was 0.73, which equals to stromal of 58%. And the by Inform software, it is 0.52, which if I talk about the stroma only, we are talking about 66%. HER2 positive cancers had the highest amount of stroma compared with both luminal and triple negative. Amount of stroma correlated significantly inversely with survival, as assessed by both softwares, the QPath and the Inform, and you can see here the significant p-values. So when I have a higher amount of stroma, I have a shorter overall survival. Okay, how did I choose my cutoff value? Actually, it is the same as the first, as Ms. Carital has chosen, the same methodology. The maximum statistical, which between brackets, lowest p-value approach was used to identify the optimal TSR cutoff for each analysis method for the whole group. The one to the left is that of the QPath, and you can see here the blue line and the red line. The blue line for the high TSR, which to simplify, tumors with low stroma, and the red one, tumors with higher amount of stroma. And this value, the 0.775, was the cutoff value that can best divide the cases into high and low stroma. The same was applied to the group to the right using the Inform software, and the cutoff value here was 0.4. Okay, in other terms, tumor/SR, the equation, the cutoff is 0.78. In general terms, or the regular terms that you will find in the literature, this is equivalent to 56%. On the other hand, in the Inform software, the TSR 0.4 is equal to a stromal percentage of 71%. Grade 3 cancers had higher, had lower stroma than grade 2, and this was significant correlation. Higher stroma were observed among inflammatory breast cancer compared with non-inflammatory breast cancer. amount of stroma as assessed by informed software correlated with number of axillary lymph nodes. So higher amount of stroma, larger number of involved axillary lymph nodes. Survival curves using these cutoffs, the one that I showed earlier for the whole cohort. And we found that in the triple negative and the HER2, tumors with higher stroma have lower survival. This is reversed in the luminal cancers. And actually there are very few papers, and they found the same, that luminal tumors with higher amount of stroma is the opposite to the general of the triple negative and the HER2. So if I have a tumor with high stroma, if it's triple negative or HER2 positive, this will have shorter overall survival, and the reverse is found in the luminal cancers. We have used two methods. The whole slide, the QPath and the selected regions and the informed software correlated with shorter overall survival by the two ways. Moreover, the results were phenotype and the method dependent. TSR assessment, especially by eyeballing on routine H&E sections, could possibly be incorporated into routine pathological diagnostics. Standardized digital analysis overseen by pathologists is required to validate results and compare data across different cohorts. Thank you.
Thank you, Dr. Mohammed, for this interesting talk and actually interesting results. Just I have a question for you. We usually report tumor infiltrating lymphocytes in our pathology report. And do you think we should also write a point about the ratio between stroma and tumor as well?
Yes.
In the pathology report.
هو ده بادئ قبل التيومر انفلتريتنج ليمفوسايتس. يمكن اول ما سالجادو اتكلم على التيومر انفلتريتنج في 2015 ده من قبلها. لكن ميزه التيلز ان هو بقى فيه كونسنسس لهاو تو اسس. يعني مثلا ان هو بيختار ريجنز معينه، بقى عنده يعني في ستيبس هيفولو عشان يعمل اسسمنت. انما لغايه دلوقتي لسه في التيومر ستروما ريشيو لسه ما فيش يونيفايد واي اوف اناليسيز. اغلب البيبرز بتتكلم عن ان انا لو هختار مثلا سيكشن او كذا فيلد من التيومر يبقى على بال 10x في فيو، وان انا لما اختار سيكشن يكون التيومر موجود في كل حروف الفيلد. وكان في بيبر حد عمل انكوربوريشن للتيومر ستروما ريشيو جوه التي ان ام، وكان ان هو مور بروجنوستيك او يعني ييلدنج مور انفورميشن بروجنوستيكالي عن الريجولار تي ان ام اللي احنا بنستخدمه.
دكتور مها الجميعي.
حسب السؤال بس ايه تفسيرك ان يعني ان الهاي ستروما ريشيو بيبقى البروجنوزس بتاعها اسوأ من اللو ستروما ريشيو في التريبل نيجاتيف؟
هي
يعني دي عكس اللي احنا الكونسبت اللي احنا عارفينه.
بس البيبرز حضرتك شفت حتى في كل التيومرز ان هي هاير ستروما correlated with worse overall survival و shorter disease free survival في كل البيبرز اللي في السوليد تيومرز الثانيه. في من شغلنا مثلا في التيومر مايكرو انفايرمنت والاميون سيلز في كتير قوي من التيلز حاجات مثلا زي اللي هم التيريج اللي هم فوكس بي 3 بوزيتيف، دول دايما correlated with worse overall. ويعني مش
اتكلم عن
انا قصدي ان دول كومبوننت الرول ممكن على الكومبوننتس بتاعت الاستروما دي. يعني ده جزء مثلا ممكن الاميون سيلز اللي موجوده في الاستروما، جزء تاني ممكن الكانسر اسوشيتد فايبروبلاستس، وده مش التوبيك بتاعنا النهارده بس برضو كانسر اسوشيتد فايبروبلاست يعني بقى موضوع يعني كومون جدا. وفي برضو يعني فاقصد الاستروما ذات نفسها يعني حضرتك كده زي بتتكلمي في الباثوبيولوجي او يعني
ريليزنج مثلا لسيرتن فاكتورز هي اللي بتخلي لك البروجنوزز ولا؟
اكيد، بس انا يعني I didn't go through it بس عشان ما اقولش حاجه مش عارفها.
The questions will be postponed after the end of session. أنا ودكتور مها الجميعي consultant of histopathology at Bahia will present a talk about PDL1 in breast cancer.
Good afternoon. My talk today is going to be about PDL1. I'm going to touch a bit on the triple-negative breast cancer, but I'm not going to talk a lot because there's a brilliant talk by my colleague about triple-negative breast cancer. I'm going to talk about PDL1 and PD1 axis and how does this work, and then I'm going to talk about, I'm going to delve into histopathology and say how do we score the PDL1 expression, and finally about the treatment. Is my voice okay? Huh? We all know that triple-negative breast cancer constitutes about 10 to 15% of all breast cancers. They lack hormone expression, they lack HER2 expression, they're usually high grade and have an aggressive behavior. They're commonly harboring mutations, BRCA1 and BRCA1 mutations specifically, and they tend to give a high rate of distant metastasis with their brain and lung. The 5-year survival for the localized disease is about 90%, and it drops to 65% when the disease spreads. We also know that genomic and transcriptomic analysis has led us to discover that triple-negative breast cancer is not one disease, it's a heterogeneous disease with several subtypes being recognized, specifically the basal-like ones, which express high molecular weight cytokeratins, cytokeratin 5 and 6. And these are further subdivided into basal-like 1, which are immunosuppressed, and they tend to have high genomic instability with a lot of deletions in genes concerned with DNA repair, like BRCA2 genes, MDM, TP53, and retinoblastoma genes. Also, we have the luminal androgen receptor ones that are triple-negative but express the androgen receptor in the nuclei. And these are also characterized by high genomic instability. And finally, the mesenchymal ones, which are characterized by expression of genes related to cell motility. Regarding PDL1 expression is expressed in 20% of those triple-negative breast cancers. And the expression of PDL1 in triple-negative is always higher than those who are not triple-negative. And the PDL1 positive tumors, they tend to have a higher number of TILs, tumor-infiltrating lymphocytes, that are CD8 positive than the ones who are not PDL1 positive. We also know that when triple-negative breast cancer metastasizes, the metastatic tumors, they usually have poorer prognosis and they have limited treatment options involving mainly chemotherapy. This is why over the past years there have been a continuous search for new treatment modalities to help these patients. Now we come to the PD1 and PDL1. This axis, the PDL1, it's a programmed death ligand 1. This is an immune checkpoint. It is expressed on normally on the surface of the antigen-presenting cells, like the macrophages. They are expressed on the surface of the antigen-presenting cells, and their role here is to interact with their receptor on the surface of the T cells, be it CD4 or CD8 T cells. And when this interaction happens, this dampens the immune response and results in decreased production of CD4 and CD8 cells, decreased cytokine release, decreased cytotoxic effects of the T cells, وبالتالي dampening the immune response. So when do we need to dampen the immune response normally in the body? In cases of chronic inflammations, in cases of autoimmune diseases, where there is a need to dampen the immune response to limit the tissue injury. If we stop this interaction, the opposite will happen. So we will stimulate the T cells. There's proliferation of the T cells, increased cytokine release by the T cells, and increased cytotoxic effect of the T cells. And this is exactly the same mechanisms that the cancer cells use. Cancer cells' expression of the PDL1, it's an adaptive immune resistance mechanism. They express this PDL1 in order to stop the T cells from attacking them, to limit the T cell directed cytotoxicity against the tumor cells. So if we again block this interaction by giving the drugs like the PDN1 therapy, we enable more and better activity of the T cells and more tumor cell death and elimination. Now coming to the histopathology part, which is what are the assays that we use to detect whether the tumors, I'm not talking about breast cancer here, usually any tumor, actually expresses PD-L1 or not. There have been several antibodies that were used, some of them by the Ventana Roche, the SP263 or the SP142. And these ones are not used for breast cancer. The only one that is used in breast cancer is the one, the dacoagilent one, which measures what we call a CPS score that we're going to talk about. And this is the one that was used in the keynote clinical trials, and this is the one that we use in triple-negative breast cancer. This antibody it's an immunohistochemical antibody. The clone is 22C3. It has been used in the keynote clinical trial to evaluate the relationship between PD-L1 expression and the clinical efficacy of the treatment, of the PD-1 treatment. This antibody has been approved by the FDA as the only companion diagnostic for using pembrolizumab as adjuvant or neoadjuvant in many clinical scenarios, like in non-small cell carcinomas, cervical carcinomas, urothelial, head and neck, and esophageal, as well as in triple-negative. But we have to make sure which scoring systems do we use. So the scoring of the PD-L1 in the different tumors is different according to the type and the location of the tumor. What we use in triple-negative breast cancer is what we call the CPS score. In other tumors, sometimes we don't use the CPS score, like for example, in the non-small cell lung cancer, we use another score, like it's called TPS, which is the total positivity score, not the CPS, which is the combined. And I'm going to explain now the CPS and then tell the difference. Again, this antibody binds to the extracellular domain of the PD-L1. The assessment of the PD-L1 staining is performed on formalin-fixed paraffin-embedded tissue that should be fixed in 10% neutral buffered saline, and the fixation should take place between 12 and 72 hours, and any fixation below 3 hours should not be used for the PD-L1 assessment. Also, this test has not been validated on decalcified material, so if we have a bony specimen that needs to be calcified, we cannot do the PD-L1. And we should avoid performing the PD-L1 staining on any stored unstained slide that are older than 6 months old. When evaluating the PD-L1, we need to have at least 100 viable tumor cells in the field that we are evaluating. We need to use positive and negative controls, of course. We should avoid using PD-L1 assessment in necrotic areas, because necrotic areas will always take the PD-L1, but we should not take them into account. Yes, we should be using positive and negative control, but it is always advised to use the tonsil as a control on the slide, because the tonsil will give strong positive staining in the cryptoepithelial cells, weak and moderate staining in the macrophages, in the follicular macrophages, and negative staining in the surface epithelium and the endothelial cells and the fibroblasts. So it's basically more of a positive and a negative control at the same time, and it also gives the grades of staining, whether strong or intermediate or weak, in the same section. So it's good to have it and make sure we are working with an antibody that is working properly before evaluating our specimen. Now coming to the evaluation of the tissue, of the PD-L1 staining in the tissue, any degree of staining, +1, +2, or +3, is counted towards scoring. So it doesn't have to be strong staining, +3, like we do with the HER2. No, any staining +1, 2, and 3 are counted towards scoring. We count the staining in the tumor cells and in the immune cells. And what I mean by the immune cells are the lymphocytes and the macrophages, the mononuclear immune cells, the MICs, lymphocytes and macrophages only. So when we're counting the tumor cells, we only count the membranous staining that should be evaluated. We should not be counting cytoplasmic staining. And I'm going to come to pictures and show you the difference in a bit and how to do that. We can also count partial and complete membrane staining. So when we talk about tumor cells, we have two things. We can count 1, 2, and 3. We can count partial and complete membrane staining, and we should not be counting cytoplasmic staining. When we come to the immune cells, because the NC ratio is usually high in immune cells, so we cannot really differentiate between cytoplasmic and membranous, so we can count both cytoplasmic and membranous as positive staining. We only count, as I said, lymphocytes and macrophages. We're not allowed to count neutrophils, eosinophils, and plasma cells, even if they stain positive. So how do we score? We use what we call the combined positivity score or the combined positive score. And this is the formula. It's the number of PD-L1 positive cells, which include the tumor cells and the immune cells. And as I said, immune means lymphocytes and macrophages. على the total number of viable tumor cells in the section, and this includes the positive and the negative, times 100. Again, I'm going to elaborate on every part of this equation. We consider it to be positive if the CPS is equal or above 10. Type. I'm going to elaborate on every part of the equation. If we take the, hello? Sorry. If we take the denominator is the total number of viable tumor cells. But which tumor cells? We're talking about only invasive tumor cells. So the in situ component is not counted, be it DCIS or LCIS, it is not counted. Again, any necrotic cell should not be counting, and here we are not counting any other cells, neither immune cells or any other cells like benign cells, stromal cells, cellular debris. We don't count any of that. Only invasive tumor cells. When we come to the numerator, we have a lot to talk about here because we're talking about tumor cells and immune cells. As I said, for the tumor cells, we'll be counting membranous staining only, not cytoplasmic staining. We can count any intensity of staining +1, +2, and +3, and we are counting only the viable invasive tumor cells. We do not count non-staining cells, we do not count cytoplasmic staining, and we do not count in situ. If we come to the immune cells, there's a bit more to talk about. As we said, we can count cytoplasmic and membrane, right? And then we are only counting lymphocytes and macrophages. We're not counting the other cells. But the thing here is we are only counting the lymphocytes and the macrophages that are adjacent to the tumor cells. And how do we define adjacent to the tumor cells? And they are present in the same 20 power field within this field close to the tumor cells. If they are outside the 20 field away from the tumor cells, then we do not count them. And I'm going to show you a picture of that. We do not count any MICs, any mononuclear cells that are related to DCIS or LCIS. So I are only counting the MICs that are related to the invasive component. We don't count the inflammatory cells that are related to the in situ. We don't count lymphoid aggregates away from the tumor, and we don't count the neutrophils and the plasma cells. And of course, other cells we don't count. I'm going to show some examples just to explain what I've just said. This is a very clear example of a CPS less than 10. It's very clearly that only very few cells are here and there, but it's very clear that this one, the first one, is a negative tumor, and it's very clear that the other one is there is complete positivity, complete linear cell membrane staining around all the cells. But unfortunately, this is not the case with the cases that we see. It's never a dreamland like that. So if we look at that one, for example, we have linear membrane staining that is distinct from the cytoplasmic. We have the arrow points at a cell that has both cytoplasmic and membranous staining. Do we count or not count this one? We actually count this one. As long as the membranous staining is distinct from the cytoplasmic staining, we actually count that cell. We also count whether the staining is granular or continuous. If we have granular staining of the cell membrane, we also count it as positive. We count it as a positive tumor cell. When we come to the immune cells, as we see here, we have immune cells close to the tumor. This is the tumor here, and it is not taking, but we have immune cells close to the tumor that are they show positive cytoplasmic staining. So these cells are also counted as positive since they lie in the same 20 power field of the tumor. And this is an example that shows that we have few cells up here taking the stain, and we have few cells down here close to the tumor cells are taking the stain. Which cells do we count and which cells do we omit? We count the ones that are down, and we omit the ones up here because they lie outside the 20 high power field of the tumor. So we put the tumor in the center of the field, and we take the 20 power field. If it's outside that field, we don't count it. Again, what not to count? We don't count DCIS. Any DCIS, even if positive, it is not counted. And the inflammatory cells around the DCIS, as it shows here, even if positive, we don't count these cells. We also don't count any fibroblasts taking the PD-L1 stain. Here we can see some plasma cells that are close to the tumor cell. It's important to refer to the H&E slide if we cannot really discern what type of cell is this on the immunostain. It's important to go back to our H&E slide and make sure these are actually lymphocytes or macrophages and not plasma cell or anything else. So again, if we go to the immunostain slide, the cells with the, the cells with the cartwheel nucleus, they should not be counted. These are actually plasma cells. Now I'm going to give certain scenarios where we can encounter when evaluating the stain. The first scenario is when we have the whole section is negative and only one single focus that represents, for example, 10% of the tumor bed is positive. How do we evaluate that? Do we just come to that and evaluate it and say there's 80% of the cells here are staining, so this is a CPS positive? No, we don't do that, because this part only represents 10% of the tumor. So after we calculate we do our formula here and we calculate, sorry. After we calculate, it turns out to be 80%. So the total number of positive cells and a total number of viable tumor cells in the field, it came out to be 80. But this 80 is not actually representative of what this tumor is. So we have to multiply it by 10% to get our score. So this is actually a score of 8 and not a score of 80. This is another scenario where we have heterogeneous staining of the tumor bed with areas that show strong staining and a lot of staining and areas that show less. So we divide our field into, as we do with the evaluation of response to therapy, we take different fields and we evaluate the score in all the fields, and then we take an average of all the fields. So here we have a score of 80 in one, 30 in one, 100 in another, and 50. So we take 4 scores, divide them by 4, and we get our CPS score. Here we have a calculation of a combined positive score that is near the cutoff value. So we have only very few cells, the brown ones, the brown circles here are the positive ones. So we have very few ones that are positive within the whole tumor. In that case, we are going to count these few positive cells, and we are going to count all the viable cells in that section. And in that case, let's say these were 16 or a positive cell, and the total number of viable tumor cells in that section is 200. We divide, and our score is 8. It is still less than 10, and it is still negative. To test or not to test? Do we always need to test for PD-L1 and triple-negative breast cancers? No, we don't have to test in all. But according to the Keynote trial 355, this study was done on advanced breast cancer, like recurrent, unresectable, metastatic breast cancers. And they proved to be that the more PD-L1 expression, the more it increased, the more the therapeutic effect of pembrolizumab also was found, and the more the duration of response to the pembrolizumab was prolonged. So this is why came up the FDA approval of pembrolizumab for the locally recurrent, unresectable, or metastatic triple-negative breast cancer if the PD-L1 score is equal to or more than 10. So in this case, where the tumor is metastatic, recurrent, or unresectable, we have to do the PD-L1. We cannot give treatment without the PD-L1. But came another publication in the New England Journal of Medicine that concluded that in early breast cancer, the breast cancers, the triple negatives that are stage 2 or stage 3, the response to pembrolizumab was much better than the response of the patients with not taking the pembrolizumab, regardless of the PD-L1 expression. So in that case, this was the Keynote 522, and they said that the response to pembrolizumab was better, irrespective of the PD-L1 staining. And this led to the new guidelines in the ASCO that says that these patients should be taking pembrolizumab as a neoadjuvant with chemotherapy and continue as adjuvant, even if the PD-L1 score, even without doing the PD-L1 score. This is the last one. So this is what we exactly do. A locally recurrent unresectable metastatic breast cancer, we do the immunohistochemistry. The pathologist reports it as a less than 1 or equal to, less than 10 or equal to 10, and then the oncologist decides the treatment. Thank you very much.
Thank you, Dr. Maha, for your interesting presentation and the valuable information you added in the scoring of PD-L1. Now let's move to our next speaker, Dr. Haizem Abdelazim. Dr. Haizem is a pathologist consultant at Bahia Foundation and a lecturer of pathology at NCI. Dr. Haizem will give us some important information about the updates of prognostic factors of triple-negative breast cancer. The floor is yours, Dr. Haizem.
شكرا دكتورة مهتاب. شكرا لحضراتكم جميعا، شكرا لجميع الحاضرين وزمايلي واساتذتي. الحمد لله دي السنة الخامسة ليا في المؤتمر بتاع بهية والسنة الثالثة على التوالي كمشارك، ف it's give me a great honor. I hope ان المحاضرة يعني تكون او التوك يعني تكون مفيدة لحضراتكم. هو الموضوع بتاعها هو موضوع اللي هو القديم الجديد، يعني على طول دايما التريبل نيجاتيف بريست كانسر بيستحوذ دايما على اهتمام جميع اللي شغالين في المجال بتاع الأونكولوجي، لأن هو still unresolved problem. So our talk today is about triple negative breast cancer updates and prognostic factors. Let's start from the scratch. Cancer is an increasing global problem, and breast cancer is not only the most common incident form in cancer in women, but it's also the first or second most common in all regions of the world. Breast cancer in Egypt, according to the last registry done at NCI, Cairo University, breast cancer constituting about 20% of total primary malignancies in adults. The classification of breast cancer. Classification of cancer enables the physicians and the cancer registrar to stratify patients, which lead to better treatment decisions and better evaluation of prognosis of the disease. How to classify breast cancer? Numerous methods are used to classify breast cancer. The conventional method is histopathological classification based on morphological appearance, and the most recent is molecular classification based on the immunohistochemical markers such ER, BR, HER2, and Ki plus or minus Ki67. According to molecular classification, which is the gold standard now, and all over the world it's the routine practice, molecular profiling based on variation in gene expression beyond the conventional use of grade and histology. It predicts clinical outcome and predicts response to therapy. Immunohistochemistry approximates the molecular category of breast cancer as defined by gene expression profiling by ER, BR, HER2, and Ki67 labeling index. In this picture, according to the receptors found on the cell membrane or on the nucleus, ER, BR in the nucleus and HER2 in the membrane, we can categorize the breast cancer into 5 groups. First group is luminal A-like, where ER and BR are highly expressed, HER2 is negative, and Ki67 is low. Luminal B-like HER2, whereas ER is positive, BR is negative or low, or high Ki67 and negative HER2. Luminal B-like HER2, where HER2 is positive, ER or BR or any Ki is found. HER2 enriched, which is HER2 only positive with negative hormonal receptors. When all receptors are absent, expression is absent, so it's triple negative breast cancer. It carries the poorest prognosis between all molecular subtypes. Triple negative breast cancer is not a unique disease. Not all triple negative breast cancer behave in the same manner, encompassing multiple entities with pronounced histopathological and genomic heterogeneity. Using plethora of gene expression tests based on the expression level of gene panels, including genes for epithelial mesenchymal transmission, which will be discussed later in this lecture, either empirically selected or using machine learning classification of the whole transcriptomic data. 7 distinct entities are described for triple negative. Till now, triple negative can be classified into 7 entities. First one is basal-like 1, basal-like 2, luminal androgen receptor, immunomodulatory, Claudin law, and mesenchymal stem-like, and mesenchymal itself. Between these 7 entities, luminal androgen receptor and immunomodulatory are carrying the good prognosis, and the mesenchymal stem-like and the mesenchymal itself have the worst prognosis. Why triple negative breast cancer is a problem? Because absence of specific targets for therapeutic strategies for this tumor, triple negative breast cancer is managed with conventional chemotherapy cytotoxic agent. Triple negative, however, triple negative showing higher incidence of complete pathologic response than other molecular subtypes. يبقى عندي تيومر عنيف جدا، البروجنوز بتاعه وحش، ورغم كده هو بيشو complete pathologic response. يعني يبقى عندي الورم، والورم ياخد العلاج، والورم يختفي تماما، والدنيا كويسه، وفجأة يرجع في وشنا. Systemic relapse with distant metastasis and different outcome associated with poor prognosis are more evident with triple negative breast cancer. How to deal with this problem? What to do to predict the prognosis of triple negative breast cancer? ممكن نروح للشيخ مستطاع علشان خاطر نعرف ايه اللي ممكن يحصل بعد كده، او ان احنا اسهل خالص ان احنا نقدر نروح للمعمل بتاع الباثولوجي ونطلب ask to help from the pathologist. The pathologist play an important role in predicting triple negative breast cancer. Conventionally زمان كان الاعتماد كله في الكانسر على الجراحة، وكان على السايز اوف تيومر والايج اوف ذا بيشنت. بعد كده الموضوع بقى تطور ان هو الفينوتايب او الهيستولوجيكال كلاسيفيكيشن والنودال ستيتس والستيج، ودلوقتي بقى البروتين او الاميونوستيكيميكال اكسبريشن والجينوميك بروفايلنج اوف بريست كانسر. كل دول بيلعبوا دور في البروجنوزيس اوف بريست كانسر. Histologic prognostic markers of triple negative breast cancer. The tumor stage is the most reliable histological prognostic biomarker in triple negative breast cancer. Larger tumor size and lymph node positivity were associated with shorter disease-free survival and overall survival. Histological subtypes, metaplastic carcinomas behave more aggressive than other kinds of breast cancer. وفي انواع من البريست كانسر من التريبل نيجاتيف بريست كانسر يعني بتبيهيف ان ا بيناين فاشون. المحاضره اللي جايه ممكن هنتكلم عن السليفري تايب بريست تيومرز، دي ار شوينج جود بروجنوزيس. في برضه اللي هو الادينوسكويمس تريبل نيجاتيف بريست كانسر، برضه تايب اوف ميتابلاستيك كارسينوما which is low grade and have a very good prognosis. So not all triple negative breast cancer show poor prognosis. Tumor infiltrating lymphocytes. Tumor infiltrating lymphocytes prognostic and predictive value mostly significant in both triple negative breast cancer and HER2 positive breast cancer. Despite the heterogeneity of immune cell types component, average tumor infiltrating lymphocytes can be assessed in our labs and as a daily routine, and it's recommended to be included in our reports. Each 10% increase in tumor infiltrating lymphocytes was associated with a 16% increase in pathological complete response. International Immuno-Oncology Biomarkers Working Groups published their guidelines, and it's I think it's now known by most of pathologists. في طريقه معينه ان احنا ازاي نحسب التيومر انفلتريتنج lymphocytes وبنكسبريس عنها as a continuous percentage. If it's 0 to 10% it's low, 20 to 40% it's moderate, 50 to 90 is high, or high stromal infiltrating lymphocytes, which is carries a good prognostic factor. Why tumor infiltrating lymphocytes? Tumor infiltrating lymphocytes هي الحاجة الوحيدة اللي in direct contact مع الورم. Nothing on earth هتبقى حاجة هتبقى عارفة tumor cells more than your own cells. So it's a real war between tumor cells and tumor infiltrating lymphocytes. But unfortunately not all soldiers are faithful. بعض السولجرز دولت بيبقوا self shooting أو بيبقوا مضرين اكتر ما هم نافعين لمحاربه الكانسر. هنا بيظهر الرول بتاع البريدكتيف ماركرز في التيومر ماركر انفايرمنت، ان احنا نعمل immunohistochemistry علشان نعرف الكومبوزيشن بتاع التيومر انفليتيك ليمفوسايتس. بنستخدم السي دي 4 السي دي 8 السي دي 73 الفوكس بي 3 سي دي 163 and it's found that high CD8 and low CD163 في tumor center in direct contact with tumor and high and low CD8 with high CD163 an invasive tumor margin showing favorable prognosis. CD8 اللي ما يعرفش CD8 هي cytotoxic cells، فهي الحاجه يعني الرول بتاعها انها direct killing of tumor cancer cells. predictive markers في التيومر سيلز نفسها اللي احنا كنا بنتكلم عليه، بنتكلم على التيومر infiltrating lymphocytes. Some markers can be expressed in tumor cells itself and give us a prognostic value. Expression of several immunohistochemical markers may show reliable prognostic impact like Ki-67. especially in private sector لحد دلوقتي يعني روتينلي بيتعمل ER BR وHER2 والكي اي بيتعمل معاهم from the first as a first panel. انا ممكن يعني اتس نوت ا روتين فور تريبل نيجاتيف بريست كانسر ان انا اعمل له كي اي، ولكن اذا كان جات لي الشرايح وفيها فعلا الكي اي 67 معمول از فيرست بانل وكان فيها كي اي 67 ممكن ده يجيف مي بروجنوستيك تول فور بريدكشن اوف تريبل نيجاتيف بريست كانسر. سبيشالي لو الورم عندي صغير مقاسه اقل من 2 سم والكي اي 67 بتاعه لو it carries a significantly better overall survival than Ki-67 high groups. يعني up to it's not proven but it up to ان في يعني studies بتقول لو التيومر عندي stage 1 والكي اي 67 low it's doubtful benefit from chemotherapy. ممكن اتجنب العيان ان هو ياخد chemotherapy as needed. It's not established but some studies pointed at this point. الكات اوف فاليو اللي هستخدمه في الكي اي 67 اللي موجود في الليتريتشر 30 to 35% is suggested to be used for further classification of triple negative breast cancer. البي 53 المعروف ان البي 53 ده اسمه الجارديان اوف ذا جينوم، موجود على كروموسوم 17 encodes for B53 transcription factor. It's play a vital role in determining the cell fate exposed to DNA damage. يعني المفروض لما يحصل DNA damage البي 53 لو الدمج ده اتصلح بيكمل السيل سايكل، لو الدمج ده ما اتصلحش بيدخل السيل دي في ابوبتوزيس ويمنع ان هي تتحول لكانسر سيل. Studies suggest that B53 gene is the most frequent mutated tumor suppressor gene in human malignancy. 30% of breast malignancy have B53 mutation. Triple negative breast cancer من ال 30% دول have the biggest share. B53 mutation stimulates cell proliferation and render aggressive phenotype. Detecting mutation في البي 53 بنقدر نعمله على التيشو اللي موجود عندنا preserved tissue formalin fixed paraffin embedded tissue even لو محفوظ عندنا بقاله فترة. So B53 positivity was correlated with worse prognosis in triple negative breast cancer. لو عملت combination ما بين البي 53 والكي اي 67 لو لقيت التيومر اللي عندي positive for B53 mutated B53 والكي اي 67 عالي high proliferation index هيبقى much more worse prognosis than the negative B53 and low KI 67 proliferation. الاندروجين ريسبتور increase expression في التريبل negative breast cancer in 10 to 50% of cases. Lack of androgen receptor يعني الاندروجين receptor لو negative considered to be a factor associated with higher risk of disease recurrence. Taking into account the sensitivity of tumor to systemic therapy ممكن استخدم كمان الاندروجين receptor antagonist in clinical practice and it's a promising for in this concern. الHER2 status in triple negative breast cancer. احنا قلنا في الاول خالص ان التريبل نيجاتيف ده is showing no triple negative يعني ER و BR و HER2 الثلاثه نيجاتيف but not all HER2 negative are the same. علشان اقول HER2 negative عندي 3 conditions يا اما يبقى HER2 0 score 0 او HER2 score 1 او HER2 score 2 which is not amplified by ISH. So it's not all the same. The latter two categories اللي هو HER2 score 1 و HER2 score 2 negative by ISH أو SISH أو FISH ده بيعتبر HER2 low which have now emerging in the field of medical oncology وفي target therapy موجود ليه so it's a promising for triple negative breast cancer cases. Although no established relationship yet, many studies pointed that patients with HER2 low breast cancer had significant longer disease-free survival and overall survival than did those with HER2 immunohistochemistry 0. But it's not established yet. But it pointing at لو أنا عندي HER2 low هيبقى عنده فرصتين كمان يعني اللي هو بالستاتستيكالي بيلاقوه أحسن في الديزيز فري سرفايفل وعنده فرصة كمان إن هو ياخد اللي هو الهيرتو اللي هو هيرتو لو. الاميون تشيك بوينت بروتينز دكتوره مها مشكوره وضحتها لنا يعني ان التيومر سيلز يوز سيروتونين تو بوست ذا برودكشن اوف اميون انهبيشن. لازم تعمل اميون انهبيشن عشان تقدر تعيش. بتعمل القصه دي ازاي؟ ان هي بت سايلنت التي سيلز عن طريق ان البي دي ال 1 اللي موجود في التيومر سيلز بيمسك في البي دي 1 اللي موجود في التي سيلز rendering it dysfunction كده هو وقفها. So increased expression of PD-L1 in tumor cells is generally associated with poor prognosis لأن كل ما هيزيد عدد ال PD-L1 tumor cells كل ما هيقفل لي أكتر الاميون response. So it carries a poor prognosis. Increased expression was observed in 20% of triple negative breast cancer cases. Expression of PD-L1 in tumor and its metastasis in the lymph node is very heterogeneous and it changes in time. عشان كده بنعمله على التيومر نفسه وبنعمله على metastatic site. ممكن تكون the problem is a solution in the same time. يعني على الرغم ان هو البي دي ال 1 ده معاه بور بروجنوزس لكن ممكن يكون هو الحل ان انا ادي immune checkpoint inhibitors anti PD-1 وانتي بي دي ال 1 with it's adjuvant with cytotoxic drugs اللي هو conventional chemotherapy. Reported prolongation of progression of free survival and overall survival upon use of a checkpoint inhibitors بتجيب نتيجة كويسة مع التريبل نيجاتيف بريست كانسر. آخر حاجة هنتكلم عنها اللي هي البريست كانسر جين اكسبريشن بروفايلز. دي بقى الحاجة اللي هي اللي يعتبر مستنينا في المستقبل عن طريق النكست جنريشن سيكونسنج عن طريق الماشين ليرنينج عن طريق الارتفيشال انتليجنس. ده اللي هيلعب رول كبير جدا ان هو يحدد التريبل نيجاتيف بريست كانسر بيهيفير. الرحله بتاعت البريست كانسر من ساعه ما بتبدا في البريست داكت وتعمل انفيجن للستروما وبعد كده توصل للبلاد فيسل وعشان توصل للبلاد فيسل بتعمل حاجه ايبيثيليال تو ميزنكايمال ترانسميشن وتلوز الاكادهرين عشان خاطر تقدر تتحرك بسهوله وتدخل البلاد فيسلز وتمايجريت لمكان تاني ديستنت بعيد وبعد كده تريفرس العمليه تاني من الميزنكايمال للابيثيليال وتعمل هومينج. كل القصه دي ديترمايند جينيتيكالي. كل ده في جينز مسؤوله عن كل حركه من الحركات دي وكل خطوه من الخطوات دي وكل باثوي من الباثويز دي. امونج كل الباثويز اللي موجوده دي يعني النكست جنريشن سيكونسنج والماشين ليرنينج قدر يحدد 50 50 gene signature included in triple negative breast cancer بيفرقهم عن other types of breast cancer و especially those genes اللي هو BCL11A, S100B, CT83 and POU2AF1 which have been identified as potential triple negative breast cancer prognostic hallmark genes based on their significant in association with distant metastasis free survival in triple negative breast cancer. Take home message: not all triple negative breast cancer will behave similarly. Tailored personalized therapy and identification of new potential targets and the development of a specific target therapy is a pivotal for improvement of existing clinical outcomes. The knowledge of crucial participation of immune system in carcinogenesis significantly extend the range of therapeutic options. Ongoing clinical trials testing different types of molecules may pave the way for effective pharmacological synergy and better treatment results. Thank you.
Thank you, Dr. Hazem, for a very nice presentation. And now we will go to the next talk. Where is Dr. Yasmin? Dr. Hazem will continue with us, and Dr. Yasmin will share him to the next talk, a radiology pathology correlation, salivary gland-like breast tumor.
First, I want to introduce Dr. Yasmin Jamil, radiology specialist at Bahia Foundation for early detection of breast cancer and treatment. It will accompany us in this lecture to introduce the salivary gland-like breast tumors. ممكن ناس أول مرة تسمع عن قصة إن أنا ممكن ألاقي salivary gland-like breast tumors في البريست, but it happens, موجودة وبنشوفها و challenging. ويعني it will be highlighted in this lecture, and I hope all of us benefit from this talk.
Salivary gland-like tumors of the breast, radiology, pathology correlation. What are they? Their classifications, radiological and pathological features, and also impact of their types on management. They are classified into benign and malignant tumors. The WHO recognizes them as several special types of breast carcinomas that share morphologic, immunophenotypic, and molecular genetic features with salivary gland carcinomas. They are triple negative, yet have much better prognosis than conventional triple negative carcinomas. However, in most cases, they behave as low-grade tumors, and they do not require chemotherapy like conventional triple negative tumors of the breast do.
According to WHO classification, salivary type breast tumors are classified into benign tumors including polymorphic adenoma, myoepithelioma, benign type of myoepithelioma, basal cell adenoma, and adenomyoepithelioma. While malignant tumors include adenoid cystic carcinoma, secretory carcinoma, mucoepidermoid carcinoma, and polymorphous adenocarcinoma. There is a special type which is actinic cell carcinoma, which requires separate mention as a breast carcinoma that shares some morphologic similarities with actinic cell carcinoma of the salivary gland, but appears to have different molecular pathogenesis based on recent evidence, lacking the ATV6 mutation characteristic for the actinic cell carcinoma in salivary gland tissue. Reported cases all over the world are 20 cases. اللي يلاقي ال 21 انا معاه في الكيس ريبورتد ان شاء الله. Salivary gland-like breast tumors show mixed epithelial and myoepithelial differentiation like polymorphic adenoma, basal cell adenoma, adenomyoepithelioma, وadenoid cystic carcinoma. Some others show epithelial differentiation only. So we have tumors may be mixed epithelial and myoepithelial, with tumors pure epithelial differentiation like actinic cell carcinoma, mucoepidermoid carcinoma, polymorphous adenocarcinoma, and secretory carcinoma. Several tumors can occur in both breast and salivary gland and exhibit overlapping morphological features, protein expression profiles, and often have shared molecular pathogenesis. These entities can sometimes be in the differential diagnosis or have overlapping features with other types of breast carcinoma. So I have to differentiate between the salivary gland type themselves and to differentiate between salivary gland type and the triple negative breast cancer, which share some morphological similarities. Therefore, recognition of their unique features and use of immunohistochemical surrogates for gene rearrangement can facilitate the diagnosis. Accurate classification of these tumors can have important prognostic and treatment implication. لما شخص حاله تريبل نيجاتيف ان هي salivary gland type breast tumor غير لما شخص تريبل نيجاتيف breast cancer of breast duct origin.
The radiological features include benign and malignant. The benign types are pleomorphic adenoma and myoepithelioma, predominantly in adult women. Their location is mainly periareolar region and they do not exceed 2 centimeters in size. They are rounded, similar to fibroadenoma. Basal cell adenoma predominantly in postmenopausal women with mean age of 70 years, retroareolar in location, and they do not exceed 2.5 centimeters. They are well circumscribed nodular lesions. Other types are adenomyoepithelioma, which is categorized to benign, atypical, and malignant. The benign type sometimes present with cystic changes and calcifications. The atypical type shows overgrowth and infiltrative growth pattern. Local recurrences are more frequent in atypical type. Malignant type show malignant features as the atypical adenomyoepithelioma and is classified into in situ, invasive, and adenomyoepithelioma with invasive carcinoma. Malignant forms include adenoid cystic carcinoma. It is invasive carcinoma, generally triple negative, predominantly in adult women. Location is also retroareolar and it is well circumscribed, maybe solitary or multifocal. It may mimic a benign lesion in ultrasound, but it has excellent prognosis in most cases. Local recurrences may occur after breast conserving surgery, especially in patients with multifocality. However, lymph node metastases and distant visceral metastases are very unusual in the classic type. Other types include mucoepidermoid carcinoma, polymorphous adenocarcinoma, secretory carcinoma, and actinic cell carcinoma. In this case, a female 50 years old presented with palpable right breast lump. Right mammography showed right breast upper outer quadrant paraareolar irregular speculated dense mass, measuring about 6.2 and with tenting of the underlying muscle. Ultrasound showed the paraareolar irregular hypoechoic solid mass.
True cut biopsy was done outside Bahia and was referred to us for a slide review. Diagnosed outside Bahia was invasive duct carcinoma grade 1, but the referred immunostained slides and confirmed by repetition at Bahia Center, showing ER negative, BR negative, and HER2 negative, raising suspicion that it's not a duct carcinoma, but it is adenoid cystic carcinoma with its morphological characteristic and negative for hormonal and HER2 receptors. Diagnosis upon slide review, diagnosis changed from invasive duct carcinoma grade 1 to adenoid cystic carcinoma. MDT decision is for simple mastectomy and sentinel lymph node biopsy. Mastectomy specimen was received at the pathology department, included a firm nipple and serious section showed paraareolar upper outer quadrant firm white mass measuring 6.5 by 3 centimeters. Microscopic findings. Upon examination, microscopic examination, we can see here the characteristic features of adenocystic carcinoma, the cribriform-like pattern, cylindromatous morphology, the lumen is filled by, some of lumens are filled by pink eosinophilic material, 2 cell types, and solid areas. So it's not one adenocystic carcinoma, it's a grade 2 adenoid cystic carcinoma. It's, here is a higher magnification showing near infiltration of one of the major ducts of the nipple to the right side. And lymph nodes, sentinel lymph nodes were all negative for tumor metastasis. ER and BR were repeated again. Both shows complete absence of nuclear reaction, which denotes negative ER and PR staining. The final diagnosis was adenoid cystic carcinoma, grade 2, PT2N0, according to sentinel lymph nodes. Second case is with Dr. Yasmin.
A 54-year-old female presented with right palpable lump. The mammography showed a right breast lower outer quadrant, well-circumscribed, dense lesion with partially obscured margin, indistinct anterior margin, showing large, dense macrocalcification. The ultrasound showed right breast 6 to 7 o'clock iso-echoic solid mass with internal gross echogenic calcifications, casting marked posterior shadowing, and surrounded by mild desmoplastic reaction. It also showed vascularity within on color Doppler application.
True cut biopsy was done at Bahia Center, showing this morphological pattern, some solid ducts and other with lumens within loose stroma, bland morphology of the tumor cells. The cells was initially suspected to be invasive carcinoma, to be honest. But this loose myxoid stroma and this mature bone spicules is not in favor of a malignant process. So we suspected it as not to be an invasive carcinoma. It's a salivary gland type benign tumor confirmed by a myoepithelial marker, cytokeratin 5/6, which show this diffuse reaction. This case can be very easily interpreted as malignant, and the patient will receive over treatment and will have comorbidities and unneed procedures for her case. ER is negative. Diagnosis based on true cut biopsy was biphasic epithelial and mesenchymal tumor for complete excision with the main possibility of polymorphic adenoma. The MDT decision was wide local excision. We received the wide local excision at pathology department. We found a mass 4.5 by 4 by 3 centimeter, which is much little bigger than usual for benign adenoid cystic, for polymorphic adenomas. Microscopic findings, a well-circumscribed mass encapsulated with 2 patterns, mesenchymal and epithelial. This is the epithelial component, and this is the mesenchymal component, with mature bone shown in the true cut biopsy, and loose myxohyaline stroma characteristic for polymorphic adenoma. S100 was positive as a myoepithelial marker. The final diagnosis was benign polymorphic adenoma. Take-home message.
Salivary gland-like breast tumor diagnosis may involve different modalities and techniques to evaluate the rare neoplasms. Mammography are not sensitive nor specific, but can show the associated skin thickening or nipple retraction in cases of malignant tumors. Ultrasound is useful in detection and characterization. It also can guide core biopsy for histopathological confirmation. MRI is considered the best imaging modality as it can provide detailed information about the tumor size, location, extent to the surroundings, and also the enhancement pattern and diffusion characteristics. CT is not routinely used as it has limited soft tissue resolution, but it can be used for staging and follow-up for patients with metastatic disease. PET-CT may be useful in cases of high-grade malignancy or cases with aggressive behavior.
Salivary gland-like breast tumors are rare and histologically similar to their salivary gland counterparts. The diagnosis is challenging because they present different histologic patterns and require careful histologic assessment, immunohistochemistry results, and even molecular-based diagnosis. Most salivary gland-like breast tumors are tumors of favorable prognosis, as opposed to triple-negative breast tumors, so differentiation between both is essential and mandatory. However, tumors with high-grade, even salivary gland type, with metastasis may require systemic chemotherapy. Thank you.
Thank you, Dr. Hazem and Dr. Yasmin, for your nice presentation. Now we come to the next presentation, titled Radiology Pathology Correlation, Ductal Carcinoma in Situ, will be introduced by Dr. Dina Swede as a pathologist in Bahia Foundation, and Dr. Inji Abdallah, a radiologist in Bahia Center for Breast Cancer. Okay.
Good afternoon. Our lecture will be about the DCIS, radiological pathological point of view. What is a DCIS? DCIS is a neoplastic profilation of mammary ductal hyperplasia, mammary ductal epithelial cells confined to the ductal lobular system without evidence of invasion through the basement membrane into the surrounding stroma. DCIS is a non-obligate precursor for invasive breast cancer, yet an increased risk of developing invasive cancer with increased the nuclear grades are appreciated. On radiological basis, we have two types of DCIS, calcified and non-calcified DCIS. First of all is calcified DCIS. 80% of DCIS present as asymptomatic calcification with fine polymorphic, fine linear or linear branching calcification are more likely to be found in high-grade DCIS, whereas amorphous and coarse heterogeneous calcification are associated with low-grade DCIS, with no definite correlation between the BI-RAD-based skin descriptors and the nuclear grade. With the distribution of grouped, segmental, and linear distribution are observed in suspicious calcifications. With regards to the measurement, accurate measurements of the extent of calcification and their distance from the nipple should be reported in all our reports.
This case show intermediate grade DCIS with evident microcalcification. It is important to identify the location of calcification, however present in the DCIS or invasive component if present, or present in non-neoplastic breast tissue. The extent of DCIS is an important factor in patient management. However, mammographic assessment of DCIS, usually based on the distribution of calcification, frequently underestimate and sometimes overestimate the extent of DCIS. Microscopic examination of the DCIS extent could be done through, if the DCIS is present in one slide, the size on the slide could be used. If present between two opposing margins, the distance between the margin could be used to assess the extent. A large serial sequential sampling of the specimen is done, and the DCIS measure can be determined from the location of the involved block.
Non-calcified. The other type is a non-calcified DCIS, which can present in the form of mass, palpable mass or not, palpable asymmetry with or without nipple discharge, pathological nipple discharge, or distortion.
On the core biopsy, the case diagnosed as DCIS intermediate grade no calcification, no necrosis, no stromal invasion. However, in excisional biopsy, focal stromal microinvasion was seen. Stromal microinvasion is defined as presence of invasive stromal component of any histological type in an area less than 1 millimeter in size. DCIS also could be associated with invasive stromal component, which could explain the presence of positive lymph node metastasis in case of DCIS. The term extensive intraductal carcinoma, major DCIS, should be applied only if the DCIS represents 25% or more in an area within and outside the invasive carcinoma, or if DCIS is associated with a small invasive carcinoma of 10 millimeter or less. The ideal margin width for DCIS and DCIS with microinvasion is at least 2 millimeter from the inked margin. However, free inked margin is sufficient for invasive carcinoma regardless the extent of DCIS. If DCIS present on the margin, the extent of margin involvement should be reported. However, focal, intermediate, or massive. In this case, the margin is inadequate, with extensive DCIS is seen close to the margin, which could indicate residual disease and require further post-operative radiological correlation.
With an average risk 25.9 of cases diagnosed with DCIS on TrueCut biopsy to be upgraded to invasive cancer on surgical incision, and to reduce such upgrade, the average number of cures are from 4 to 6 cures, and to have the cures from the whole affected area for better assessment of the tumor behavior. To have biopsy from the area of most suspicion, not the area feasible for biopsy. And in case of calcification, the cores are assessed by mammographic view to ensure the presence of calcification. And for rebiopsy, if indicated, it's obtained through the VAB to obtain larger specimen for assessment.
This case presents radiologically by widespread microcalcification. On core biopsy, only one duct with atypical intraductal epithelial proliferation with no associated calcification was seen, so the case diagnosed as category B1. However, serial level from the block was done, and the stromal calcification was seen, upgrading the case into B3, benign but of uncertain malignant potential. On VAB biopsy, DCIS with calcification and necrosis was evident, upgrading the case into B5A in situ carcinoma. The nuclear grade of DCIS is an important predictive factor and classified into low grade, intermediate grade, and high grade based on 6 morphological parameters.
Regarding the impact of nuclear grade on our enhancement pattern, pathological mass and/or non-mass enhancement was associated with almost all cases of high-grade DCIS and some cases of intermediate DCIS. And less pathological enhancement was elicited with low-grade DCIS and some cases of intermediate-grade DCIS. Such as this one, it's a low-grade, very faint enhancement. We should here concise to the suspicious calcification seen on 2D images. We have now some clinical presentation of special cases of DCIS. احنا هنحتاج هنا حد يبقى معانا مشاركة. يلا, let's check this lady. She's a 60 years old lady. This is her mammogram. ACRA, no speculated masses, no calcifications. What's your opinion? She can go home safely with such mammogram. But regarding her clinical presentation with nipple ulceration, which is persistent after medical treatment, what to do? We should biopsy. What to biopsy? We have no suspicious criteria. We will do wedge biopsy from the nipple, and it came up with Paget disease of the nipple with DCIS. The journey didn't end. We will continue with MRI to assess the extent of enhancement, which is here linear, heterogeneous, non-mass enhancement extending from the nipple to the posterior third of the breast.
nipple wedge biopsy revealed Paget disease. Paget disease defined as presence of malignant glandular epithelial cells within the stratified squamous epithelium of the nipple, which is confirmed by HER2 positive. HER2 in this case is of diagnostic, not of therapeutic value. Associated DCIS was seen and was HER2 negative, and the management of Paget disease depend on the presence of DCIS or invasive cancer.
Our second case is a 30-year-old lady present with left breast spontaneous bloody nipple discharge. Our ultrasound revealed left breast upper inner altered area of altered parenchyma with prominent ducts. So mammogram was done revealing no calcification, no speculated masses, no suspicious area. So we had our contrast, and we have a segmental non-mass enhancement extending and reaching the nipple.
Nipple discharge showed tissue fragment of epithelial cells with moderate nuclear atypia classified as suspicious. In patients even with normal radiological finding, a suspicious or malignant result is an indication for surgery. On excision, DCIS intermediate and grade of micropapillary and cribriform pattern was evident.
And our third case was a 57-year-old lady with palpable right breast lump. Her mammogram revealed circumscribed, rounded, equal density mass. By ultrasound, no, it was with angular margin, irregular, hypoechoic, with cystic changes, and it's not even parallel to the breast tissue.
Diagnosed as solid papillary carcinoma with no stromal invasion.
Our fourth one is a 62-year-old lady with palpable left breast lump. We have here a left breast posterior third, circumscribed oval, equal or high density mass. By ultrasound, also same features, mass with irregular mass, not parallel, with angular margins or microlobulated margin and cystic changes, newly palpable. Pathology revealed
encapsulated papillary carcinoma with no stromal invasion. Despite encapsulated papillary carcinoma and solid papillary carcinoma are diagnosed by WHO as in situ carcinoma, however, they lack myoepithelial expression at the periphery of the lesion. The pathology report for DCIS should include the following parameter: morphological pattern, the grade of DCIS, presence of necrosis, presence of calcification and dislocation, hormonal status, namely ER, stromal invasion, extent of the focus, and marginal status in excisional biopsy.
And to sum up, if we have suspicious calcification detected by mammogram, depending on morphology and distribution, we will do biopsy. Concordant radiological pathological results, so clinical management will be done respectively. But if not concordant, rebiopsy with BiVAP. If we have pathological nipple discharge, and let's define what is that pathological nipple discharge. It's unilateral, uniorificial, spontaneous, without pressure, spontaneous, bloody, or serous nipple discharge. If we have associated suspicious radiological findings, so we'll go for biopsy. No radiological findings, cytology will be done. If suspicious result, further contrast-based study and the clinical management is mandatory. Nipple change is resistant to medical treatment. If we have also suspicious radiological findings, so we'll go for biopsy. No radiological findings, we will do wedge biopsy from the nipple. If Paget was diagnosed, MRI is to be done to assess the extent of suspected associated DCIS. And lastly, recently palpable lump. Suspicious, if we have suspicious radiological findings, mass with cystic changes, internal vascularity, not parallel, or even palpable area of altered parenchyma with prominent ducts, biopsy is to be done. Radiological, pathological concordance, hand in hand with clinical findings, clinical presentation of our patient are mandatory. Any inconcordance, rebiopsy, contrast study, ending in surgical excision are to be done. Our take-home message will be 80% of DCIS present as non-symptomatic calcification, and the other 20% present as palpable lump, pathological nipple discharge, or nipple changes. So respecting the patient complaint is a key point for diagnosis. In patients with pathological nipple discharge diagnosed with a suspicious or malignant result in cytology, it's an indication for further clinical management, even if no suspicious radiological findings were found on basic sonomam. Contrast-based study is recommended in cases of intermediate and high-grade DCIS to assess the accurate extent with respect to suspicious morphology of calcification in case of non-enhancing low-grade DCIS. With around 25% of upgrade of DCIS on excision, proper radiological pathological concordance should be obtained. And thank you.
Thank you so much, Dr. Inji, Dr. Dina, for these very nice cases. And the last about to respect the patient complaint. This is a very important. Thank you. The next talk, Dr. Amira Karam will share Dr. Dina again to talk about radiology, pathology correlation, spindle cell tumors.
Okay, thanks. Thanks, Dr. Sheil. Spindle cell lesion, radiology, pathology correlation. What are breast spindle cell lesions? A relatively rare group of lesions characterized by a significant proliferation from mesenchymal tissue with or without epithelial proliferation. They range from reactive benign lesion to high-grade malignancy. Breast spindle cell lesion could derive from myofibroblast within the intra and interlobular stroma in response to trauma in case of a scar, hormonal change in case of cellular BASH and myofibroblastoma, and non-etiology in case of nodular fasciitis and others. It could derive from intralobular stroma only in case of phalloides tumor. From the fascia of pectoral muscle or Cooper's ligament in case of fibromatosis. Spindle cell lesion of the breast could be a component of myoepithelial tumor in case of adenomyoepithelioma, or may represent a metablastic change of invasive carcinoma through epithelium mesenchymal transition in case of metablastic breast carcinoma. They may be derived from non-breast specific tissue, such as skin, fat, muscle, and blood vessel, or rarely metastases from spindle cell tumor, commonly melanoma.
They are classified according to behavior into benign tumor-like lesions. The scar is the commonest one of them. Then PASH, benign phalloides tumor, myofibroblastoma, hamartoma, spindle cell lipoma, nodular fasciitis, mammary schwannoma, traumatic neuroma, and locally aggressive as fibromatosis or desmoid tumor, borderline phalloides tumor, and this group has a risk of local recurrence. Malignant lesions, metaplastic breast carcinomas, this is the commonest one of them, then malignant phalloides tumor, angiosarcoma, malignant fibrous histiocytoma. Radiological features of spindle cell lesions, although a definitive diagnosis of these lesions cannot be made by diagnostic imaging alone, some of them exhibit characteristic features at mammography and ultrasound. As they have a wide spectrum, we will discuss the commonest types. Benign lesions at mammography usually appear as a partially circumscribed oval or rounded mass with or without calcifications. At ultrasound, appear as a well-defined hypoechoic solid mass with regular or lobulated outlines, harboring cystic changes or increased vascularity, mimicking atypical fibroadenoma, as shown in these cases, all of them mimicking typical fibroadenoma, harboring cystic changes or increased vascularity. Borderline lesions, fibromatosis, at mammography presents as a distorted area or even speculated non-calcified mass that appears suspicious for malignancy. At ultrasound, as hypoechoic mass of irregular borders, speculations with no significant internal vascularity. Borderline phalloids, at mammography seen as a large rounded oval or lobulated well-circumscribed lesion of high density. At ultrasound, inhomogeneous mass harboring cystic spaces demonstrating posterior acoustic enhancement with increased internal vascularity. Malignant lesions, Metaplastic breast carcinoma has a variable appearance in imaging studies. At mammography, it appears as a rounded or lobulated mass that may harbor suspicious calcifications or overlying skin thickening. Speculations and parenchymal distortion of the surrounding tissue may be seen in some cases. At ultrasound may show complex echogenicity and posterior acoustic enhancement. Malignant phylloids. The aggressive growth pattern can result in a large tumor size with increased cystic changes of breakdown as well as increased vascularity in ultrasound. Yet in some cases, mammography and ultrasound cannot differentiate between malignant phylloids from other benign and borderline types.
The role of pathology in diagnosis of breast spindle cell lesion in core biopsy. We classify the cases into bland appearing low grade and malignant appearing high grade spindle cell lesion. At this step, we should exclude metaplastic breast carcinoma, since it should require axillary lymph node dissection. A careful search for in situ invasive carcinomatous component, as well as the use of immunohistochemistry, could be helpful in diagnosis. The bland appearing, all the bland appearing group, otherwise the metaplastic breast carcinoma, are categorized as B3, and the management excision with adequate safety margin, and be classified into biphasic and monophasic tumor. Biphasic means presence of spindle and epithelial component, and monophasic formed of pure spindle cell tumor. If the margin of the lesion could be identified in the core biopsy and it was infiltrative, could indicate borderline or malignant lesion. All malignant appearing spindle cell lesions are categorized as B5, and treatment is excision with safety margin. The role of immunohistochemistry in diagnosis of breast spindle cell lesion, we do a panel of immunohistochemical markers, at least 3 epithelial markers, low molecular weight and high molecular weight, CD34 and beta-catenin. If the tumor was diffusely positive for any epithelial marker, the diagnosis of metaplastic breast carcinoma could be established. If negative, the bland appearing spindle cell lesion could be positive for CD34 in case of phylloides tumor and myofibroblastoma, and the diagnosis could be made in the context with the morphological features. Beta-catenin positive bland appearing spindle cell lesion include fibromatosis. For malignant appearing breast spindle cell lesion, CD34 is positive in malignant phylloides tumor and angiosarcoma, and additional immunohistochemical marker can be helpful in the differential diagnosis. Additional markers such as S100, smooth muscle actin, and desmin could be done, but better in excisional biopsy. However, some metaplastic breast carcinoma are negative for epithelial marker in 30% of cases, could be focal positive for beta-catenin. In addition, B63 could be positive in malignant phylloides tumor, so no immunohistochemical marker is completely sensitive or specific and should be interpreted in the context of the morphology.
Illustrative cases. Case number 1. A 50-year-old female complained of a right breast lump of 6-month duration. We started with mammography, which revealed right upper outer quadrant, oval-shaped macrolobulated lesion of medium density. The ultrasound revealed oval-shaped macrolobulated lesion with few tiny cystic changes, no internal vascularity in color Doppler. So the radiological diagnosis came as pyrade 3 lesion, yet histopathological assessment was recommended regarding the patient's age and diffuse sonographic atypical criteria.
This case shows a bland appearing breast spindle cell lesion, monophasic, formed only of pure spindle cell component. So the next step, we do a panel of immunohistochemical marker, including at least 3 epithelial markers. All were negative. The tumor was positive for CD34, and the diagnosis is keeping with myofibroblastoma. On excision, the border was circumscribed.
Case number 2. A 45-year-old female complained of a right breast lump. We started with mammography, which revealed right upper outer quadrant deeply seated oval-shaped lesion of medium density with partially indistinct borders. It showed low suspicious score by AI, which were 26. In ultrasound, it revealed oval-shaped heterogeneous lesion with indistinct outlines surrounded by mild desmoplastic reaction, minimal vascularity in color Doppler application, no pathological axillary lymph nodes detected. So the radiological diagnosis came as by RADS 4 lesion and biopsy was taken.
The case also showed a bland appearing spindle cell lesion, monophasic, formed of pure spindle cell component. High power view revealed no cytological ETB. The second step, doing immunohistochemical marker for at least 3 epithelial markers, and all were negative. The tumor was negative for CD34 and positive for beta-catenin. And the diagnosis is keeping with fibromatosis. In excisional biopsy, the border was infiltrative, and again, high power view revealed no cytological atypia, as fibromatosis in the breast doesn't accept any degree of cytological atypia.
Case number 3, 64-year-old female complained of a right breast lump for 1.5 month duration. We started with mammography, which was very dense, ACRC breast, showing right upper outer quadrant obscure density corresponds by ultrasound to an oval-shaped mass with differential echogenicities and partially indistinct deep margins. The radiological diagnosis came as by RADS 4B. Contrast study was done for better characterization and to rule out multifocality and multicentricity. Contrast-enhanced digital mammography was done and revealed right upper outer quadrant, single, irregular, heterogeneous, intense mass enhancement, no ipsilateral axillary suspicious lymph nodes detected, and biopsy was done.
Again, the lesion formed of bland appearing spindle cell lesion, monophasic. However, focal infiltrative border could be identified in the biopsy, and minimal degree of cytological atypia was seen, which raised the concern for metaplastic breast carcinoma. We do epithelial markers, and low molecular weight cytokeratin was negative. However, high molecular weight cytokeratin were positive. And the diagnosis is keeping with metaplastic breast carcinoma, fibromatosis-like, and the hormonal profile and HER2 were negative, triple negative. On excisional biopsy, confirms the infiltrative nature of the lesion, some degree of cytological atypia, and in thorough sampling, a minor invasive carcinomatous component was seen, confirmed by immunohistochemical marker for epithelial.
Take-home message: the most important challenge in the diagnosis of breast spindle cell lesions is the exclusion of metaplastic carcinoma, either fibromatosis-like or sarcomatoid carcinoma. Radiologists shouldn't underestimate benign-looking lesions with atypical features and proceed for biopsy. A collaborative diagnosis is reached using clinical findings, radiological pathology, and a panel of immunohistochemical markers. Thank you.
Thank you, Dr. Adina and Dr. Amira, for a very nice presentation. And now we will go to the last lecture in this session. We will go to Dr. Lubna Khalid, breast imaging consultant, Bahia Foundation, assistant professor of radiodiagnosis in Al-Azhar University. She will talk about imaging features of breast cancer subtype.
Imaging features of breast cancer subtypes. Breast cancer is a heterogeneous disease with different phenotypes. Each subtype has different imaging features, treatment strategy, and prognosis. Previously, breast cancer management was depending on different schemes, namely histopathological subtypes, including in situ and invasive carcinomas with their types, grading, including well-differentiated, moderately, and poorly differentiated cancers, staging depending on tumor size, lymph node status, and distant metastasis. These schemes still don't provide sufficient information for specific therapy. هحاول انا حاسه الصوت عالي فعايزه ابعده شويه. These schemes still don't provide sufficient information for specific therapy, accurate prognosis, and survival outcomes. In the past 2 decades, this classification has been enriched by the development in the field of molecular biology, resulting in what's called molecular subtypes. Gene expression profiling has reshaped our understanding of breast cancer by identifying 4 molecular subtypes: luminal A, luminal B, luminal A, luminal B, HER2 enriched, basal-like and basal-like tumors. Each subtype has critical difference in incidence, response to treatment, disease progression, survival outcomes, and imaging features. This is a cross-section of the ductal unit showing it's lined by the luminal cells surrounded by basal cells and basement membrane. More generally, when the cancer cells show a feature similar to luminal cells, they are categorized as luminal cancers. When cancer cells show a feature similar to basal cells, they are categorized as basal-like tumors. To understand these molecular subtypes, we have to know what's called receptor states. Receptors in breast cancer cells, including estrogen, progesterone, and HER2 analysis. Receptors are proteins present in the surface of breast cells. They join or bind to the hormones like lock and key, then telling the cell to grow and divide. All breast cells have receptors, but these receptors are present in much greater number in cancer cells. The goal of treatment is to stop the signal created when these hormones bind to the receptors. So we block these receptors by hormonal therapy. For example, in estrogen and progesterone positive cancers, we use hormonal therapy to block these receptors. In HER2 enriched cancers, we use Herceptin to block these receptors. While in triple negative breast cancer, in which cells don't show any sensitivity to receptors, chemotherapy is the only option. Based on receptor status, proliferation rate, and other biomarker positivity, breast cancer has been classified into 4 major subtypes: luminal A, luminal B, HER2 enriched, and basal-like. Criteria of molecular subtypes in general: in luminal A, there is overexpression of estrogen and progesterone receptors. There is lack of HER2. In criteria of molecular subtypes, in luminal A, there is overexpression of estrogen and progesterone receptors. In HER2, there is lack of expression. In luminal A, there is overexpression of estrogen progesterone with lack of expression of HER2, low proliferation rate. Recommended therapy is a hormonal therapy with favorable prognosis. In luminal B, there is less expression of estrogen and progesterone, plus or minus expression of HER2. Proliferation rate is intermediate. Recommended therapy is hormonal and chemotherapy. Prognosis is unfavorable or less favorable than luminal A subtype. In HER2, there is overexpression of HER2 receptors with lack of expression of estrogen and progesterone. There is high proliferation rate. Recommended therapy is Herceptin and chemotherapy with poor prognosis. In triple negative, no overexpression of any receptors with very high proliferation rate. Recommended therapy is chemotherapy. Prognosis is the worst. Molecular histologic correlation of breast cancer: luminal A usually correlated with low-grade carcinomas, while luminal B, HER2 enriched, and basal-like usually correlated with high-grade carcinomas. Genetic subtyping of DCIS is not as advanced as that for invasive cancer, but the results of biomarkers studies suggest that majority of DCIS tumors express estrogen and progesterone. HER2 expression may be more frequent in high-grade DCIS. Triple-negative subtype is infrequent, but is predictive to be of high-grade tumors. Imaging features. First type, triple-negative breast cancer, which is proxy of basal-like subtype. In mammography, this is usually presented as unifocal circumscribed mass with absence of calcifications and showing posterior acoustic enhancement in ultrasound denoting intratumoral necrosis. 70% of these tumors occurring in BRCA1 mutated women. In MRI, there is characteristic post-contrast REM enhancement of these tumors with internal bright signal on T2 and significantly high ADC value. Absence of non-mass enhancement correlates with the rarity of DCIS or associated DCIS. Case number 1, above 40 patient with left breast, upper inner quadrant indistinct mass in mammography with corresponding circumscribed hypoechoic mass with posterior acoustic enhancement in ultrasound. In MRI, this lesion or mass showing intermediate signal in T2, bright signal in stare, and REM enhancement in post-contrast. Second case, mammography revealed multiple bilateral circumscribed masses with left breast upper outer quadrant indistinct mass. This mass detected in AI, the left breast upper outer quadrant mass detected in AI as highly suspicious mass. In ultrasound, there is left breast upper outer quadrant corresponding circumscribed mass with cystic breakdown and ipsilateral pathological axillary lymph node. In MRI, the left breast mass showed internal bright signal in T2, characteristic REM enhancement in post-contrast with significantly high ADC value. In positron emission mammography, this mass, the left breast mass, showed REM avid uptake. Third case, left breast lower inner quadrant indistinct mass in mammography. By ultrasound, there is corresponding circumscribed hypoechoic mass with posterior acoustic enhancement denoting intratumoral necrosis and ipsilateral pathological axillary lymph nodes. In contrast mammography, there is REM and heterogeneous enhancement of the left breast lesion. Second type, HER2 positive breast cancer features, usually presented as indistinct irregular mass in mammography, almost associated with suspicious microcalcifications. Multifocality, multicentricity, and lymph nodes involvement are common in this type. In MRI, usually presented by heterogeneous mass enhancement. Also, non-mass enhancement is a significant finding. First case, this is mammography revealed left breast upper outer quadrant focal asymmetry with suspicious microcalcifications. AI detected the left breast upper outer quadrant lesions as highly suspicious lesions. In ultrasound, there is corresponding left breast upper outer quadrant irregular hypoechoic masses along with 9 o'clock indeterminate lesion and ipsilateral pathological axillary lymph nodes. In MRI, there is left breast outer and inner or 3 and 9 o'clock heterogeneously enhancing irregular lesions along with left breast outer quadrant non-mass enhancement and associated ipsilateral pathological axillary lymph nodes. This was a multicentric malignant process. Second case, there is left breast 9 o'clock focal asymmetry harboring suspicious microcalcifications, best appreciated in magnification view. Corresponding ultrasound revealed altered parenchymal echogenicity. Third type, ER positive HER2 negative breast cancer, usually presented as speculated dense mass, more common in luminal A. Architectural distortion, multifocality, multicentricity, and lymph nodes involvement are more common in luminal B subtype. Carcinomas with BRCA2 mutations, often of luminal B subtype. In MRI, usually presented as heterogeneous mass enhancement. The presence of non-mass enhancement likely reflects associated DCIS. First case, left breast lower outer quadrant speculated dense mass is noted in mammography. This is detected highly suspicious by AI. An ultrasound corresponding irregular speculated hypoechoic mass is noted. In MRI, heterogeneous enhancement of the left breast mass with linear heterogeneous non-mass enhancement is noted. Second case, this is of luminal B subtype, left breast 12 o'clock speculated irregular dense mass is seen. In ultrasound, there is corresponding to irregular hypoechoic lesions are detected. In MRI, there is heterogeneous enhancement of the aforementioned masses are seen with restricted diffusion. Take-home message, recognizing the intrinsic molecular subtypes of breast cancer has begun to unravel the heterogeneity of breast cancer and leading to further development of targeted treatments, improving the prognosis of all women diagnosed with breast cancer. Each subtype displays unique imaging features, and the role of breast imaging in early detection continues of great importance. Circumscribed tumors with posterior acoustic enhancement, post-contrast REM enhancement, internal bright T2 signal, and high EDC value in MRI are predicted to be of triple-negative subtype. Tumors with suspicious microcalcifications predicted to be of HER2-enriched subtype. Tumors with speculated margins and/or architectural distortion are predicted to be of luminal subtypes. Multifocality, multicentricity, and lymph nodes involvement are more common in luminal B and HER2-enriched subtypes. Thank you.
Many thanks, Dr. Lubna, for your fruitful presentation, actually. We can take a couple of questions because we are running out of time. Okay.
انا شفت في البريست طبعا الكومن ستروما اللي هي الديزموبلاستيك ستروما اللي هي اكتيف فايبروبلاست وانفلاماتوري سيلز، بس في البريست فايبرو هايلايزد ستروما ويز الاستوزيس. ساعات الاستروما بتبقى مختلفه. النيتشر اوف ذا ستروما انت ما اتكلمتش عنها ان ريليشن للبروجنوزس بتاع التيومر، كان الاستروما كلها دايما نفس التايب، وزي ما كانت الدكتوره بتقول التيومر انفلتريتنج ليمفوسايتس برضه بتختلف من تيومر لتيومر، بس حضرتك عممت وقلت ان التيومر كل ما الاستروما بتاعته زادت كل ما يبقى ممكن يبقى ريليتد للباد بروجنوزس. بصرف النظر عن السب تايب بتاع الاستروما، هل حصل استادز على السب تايب بتاع الاستروما دي؟
كنت قلت للدكتوره اماني اللي هو من اول ما بداوا من 2007 وبداوا يدرسوا مجرد حتى من غير تايب نفسه نسبه الاستروما قد ايه، او في يعني مثلا في السكشن ده او في التيومر ده مثلا الاستروما بتمثل مثلا 60 او 70%. ففي خلال اكتر من 15 سنه دلوقتي تقريبا كل الاستاديز اللي اتعملت على السوليد تيومرز سواء الجي اي لانج والبريست بعدها ب3 4 سنين بدا، اغلب البيبرز دي مش محدد نوع الاستروما. يعني هو بيتكلم على ان والله فيلد ما فيهوش نيكروزس، ما فيهوش هايلينايزيشن جامد، كل ده اكسبتابل ان انا احسبه او اعمل له اسسمنت كبرسنتج. انما النوع نفسه او ايه الباثوبيولوجي اللي وراه ده اللي ممكن بقى يكون جواه مثلا هل يا ترى الاميون سيلز حتى في كان الدكتور حازم بيعرضها ان في مثلا اللي هم التي ريجولاتوري اللي هم نوع من انواع التي اللي هم فوكس بي 3 بوزيتيف، دول يعني ليهم ادفيرس افكت. هم اميون سيلز بس هم لا، هم ضارين لان هم بيدمبن الاميون ريسبونس.
بالظبط، عشان كده بقول لحضرتك نوع الاستروما بقى
بالظبط، ما دي اصلا حاجه مش هنقدر نعرفها. يعني حتى سي مثلا الاستروما هم الليمفوسايتس بالنسبه لي يعني بالاتش ان دي هم كلهم شكل واحد. السب تايبنج ده بقى يعني حتى مش مجرد يعني هم كلهم تي، هم كلهم سي دي 4
بس في حتى ايفن تيومر بتبقى فايبرو هايلايزد الاستوتيك ستروما، تلاقي ان الاستروما
هو الاستاديز اللي انا قريتها يعني ان هو لما تبقى مثلا اريا هايلايزد ستروما خالص دي اكسكلود او اشوف فوكس ثانيه، برضه هو ما
يعني
فيش
موستلي ديزموبلاستيك غالبا لو على
يعني ما تبقاش يعني اغلب الصور لا باين الاستروما العاديه اللي بنشوف في اغلب التيومرز. برضو اللي هو التيلز الاسسمنت بتاعها بدا متاخر، بس هو دلوقتي بقى ليه يعني ليه زي ليه كتالوج كده اقدر اعمله اسسمنت. ده لسه لان لسه مش متفقين على حاجه في الاخر.
طيب معلش
طب okay, excuse me because there is a session we'll start right now. Okay, sorry. Thank you for your attendance.